this session, I would like to invite Dr. Arundhati Tamuli, a prolific cataract surgeon from Lions Eye Hospital, Dibrugarh, to give her valuable opinion on early PCO. How early can we treat? Over to you, Dr. Tamuli.
Good afternoon. Thank you, Jayashi, for making me a part of this instruction course. So, early PCO. Early PCO is also known as secondary cataract or after cataract. Usually, it develops few months to year following cataract surgery. But if the surgeon's luck is bad, he shall have to face an unhappy, anxious patient within few days to weeks following cataract surgery because of this early PCO. That causes dramatic reduction in patient post-op satisfaction. So what actually it means? It's the whitening or opacification of posterior capsule following cataract surgery. So patient will again complain of decrease in vision. There may be decrease in the contrast sensitivity. He might complain of glare, photophobia, symptoms similar to that of cataract. And similar symptoms he'll get if we see any other opacity that develops behind the IOL. So coming to the types of PCO, a classical PCO has two different forms, epithelial and fibrous. If we see in epithelial PCO, the visual disturbance is more. So here, the hallmark of this PCO will get typical pearl-like opacity, which we call Alschnick pearl. Whereas in fibrous PCO, the visual disturbance, comparatively, it is less. And here, what happens, the multiple layer of lens epithelial cell, it becomes opaque and forms the fibrous PCO. This is another picture where we can see, along with the posterior capsular opacity, there is a thick capsular, fibrous capsular band, which may be because of the excessive wrinkling. This is another picture where we can see, along with PCO, there are lots of iris pigmentation, and this is because of the severe post-op inflammation. So with today's technologies and techniques, the incidence of PCO have been reduced. So rather, we can say it's been delayed. So what are the conditions that influences the development of early PCO? So first comes the age. So younger is the age group, more chances of developing PCO. So this is considered the most commonest complication following pediatric cataract surgery. And in infants, we'll see in almost 100% cases, they have a tendency to develop PCO. So what are the reasons that influences the formation of PCO in this age group? So there are multiple factorial which are responsible for the development of PCO at this age group. These are maybe their younger age group, surgical trauma during this early age group, maybe because of the associated surgical management of the posterior capsule, vitreous phase, and many factors. Sometimes this type of pediatric cataracts are also associated with other ocular pathologies, which may be one of the reasons why they develop PCO at this age group. Then second is the rhexis size. If the rhexis size is bigger and completely off the IOLs, so what happens, the anterior lens capsular epithelial cells, they comes in direct contact with the posterior capsule. And thereby they produce a alpha smooth muscle keratin, which differentiate into myofibroblasts, and they again leads to opacification. But it's very important, if there is an implant in between these two capsular bag, this will prevent migration of the cell. So it's very important that rhexis should completely cover the IOL. And if there is an asymmetric covering, we'll get severe form of PCO. So there are other factors which affect is the IOL design and the material. It's seen that in today's scenario, majority of the lenses, they are made in a biconvex format, so that the optic surface and the capsule, they remain in close contact, so that they again prevents migration of the cell. Even the square truncated edges IOL also prevents cell migration. Now, there studies have been done which showed that IOLs with hydrophobic surface, the incidence of PCO is less. So which has developed severe post-op inflammation or uveitis, in those cases also there is 20% chances of PCO formation within first year. Recently, there was a study which have showed that the fibrotic PCO formation is more with the flex rather than after phacoemulsification. This is maybe because of the thermomechanical damage to the lens epithelial cell. So these are the causes which influences the development of early PCO. So there are other causes where we may get a retroaisle membrane formation. These are retained lens cortex, capsular plaques, wrinkle capsule, capsular folds, vitreous thread, and the inflammatory membrane. So decision making in this scenario is how and when to treat. So first question comes how. So laser YAG capsulotomy is considered the preferred method to treat PCO and here it's an OPD based procedure and it is considered the safest because here we don't have to enter into the eye. And here we use the energy level depending upon the thickness of the PCO. Then we have other procedures available like needle capsulotomy. This was practiced in the era prior to the YAG laser. Even it is done in the places where YAG laser is not available. So it's considered little a crude procedure because here we use 26.5 gauge needle which is passed through the pars plana and then an incision was made into the thick capsule. But there are sometimes the incision may not be sufficient enough to give to make an opening in the thick membrane. So in that cases we go for vitrectomy. So another condition where we can go for vitrectomy is the retained cortex if we see vitreous along with the PCO. So now next question comes is when to go for this procedure. So anytime whenever the patient feels there is a decrease in the visual acuity, we can easily go ahead with this procedure. So why actually we are worried to go with this early intervention? So let's see the risk of early intervention. So first is the YAG laser. In YAG laser, we use contact lenses which may compromise with the wound stability, especially in case if the wound is large. Second, studies are there which showed the risk of cystoid macular edema and retinal detachment following YAG capsulotomy. Then with the other two procedures, needle capsulotomy and vitrectomy, both are invasive procedures, so they have their own potential risk. So now the next vital question comes, can we still intervene in the early post-op period with this procedure? So logically, yes, considering the situation. If there is an absolute indication, definitely yes, we may have to select an appropriate procedure with special precaution. So let's see how we can negate the issues with the YAG laser. So in YAG laser, majority of the surgeons, they use Abraham YAG capsulotomy lens to treat the PCO. But however, we can do it without the use of these lenses. This is possible if it needs a little experience of the surgeon, and secondly, we need little high power. So let's see, this is one of my case where I have done YAG capsulotomy without the use of lens. And I believe many surgeons does this. So here, only thing that we need little compliance from the patient because it takes little time. Only difference is that we need little high power to do capsulotomy without the lenses. Rest is all same. Second is the risk of RD. So there are many studies which have shown that the risk of RD is only 0.5 to 1% following YAG capsulotomy. That too if it is done within 5 months post-operatively. But there are studies which have shown that this risk is similar to the risk which we get following an uncomplicated phacoemulsification. So there is not any absolute contraindication to perform YAG capsulotomy in the early post-op period. So let's see some special situation like in a case of endocapsular hypopyon, which also mimics like a PCO. So in this type of cases, like we usually get a localized, the thing is that we really have to diagnose it. Like we really need to differentiate this condition from the PCO because in endocapsular hypopyon, since it is a chronic infection, post-intraocular, post-surgery intraocular infection, so here the thing is that ideally we shouldn't rupture the posterior capsule because there is a risk of endophthalmitis. Then second is your capsular distension syndrome. This is a very rare complication where the fluids get entrapped between the IOL and the posterior capsule. So in this type of cases, we will get a significant anterior chamber shallowing because there is a displacement of the IOL. So along with the PCO here in this patient, there will be rise in the IOP. So here if we do a posterior capsule, that will solve the problem. So to conclude with that, posterior capsular opacification can be treated efficiently by YAG laser even in the early post-op period without any serious complication. Special and tricky situation, however, need judicious approach depending upon the cases. Thank you.
Thank you, Dr. Arundhati, for that wonderful presentation. So any questions from the audience? Dr. Arundhati, I would like to ask you one thing. Like the report that has stated that flakes causes an increased incidence of PCOS, especially the fibrotic ones where you need a greater number or amount of energy. So what do you think is the actual cause that is contributing to the early PCO in the flex cases? Is it only the thermomechanical damage, or is it because there is only 1 or 2 reports and maybe because of the novice surgeon performing a flex, can that be a condition?
No, that study, it was done in the year 2016. In fact, there was one more study which was done in the year 2018, I think. They have taken, the first, yes, of course, in the first study, they have taken around 60 patients. And the second one, it was quite a large, like I think around 2,000 or 3,000 cases they have already done. So I don't think it's a novice surgeon. And secondly, in both the group, they have said that it's maybe because of exact cause still they cannot define, but they have said it's because of the thermomechanical damage to the lens epithelial cell.
Okay.
And maybe that's what they have said.
Yeah, that is what has been stated
still
actually.
They have to further do the, like, with
I just want to ask you, Dr. Arundhati, like, what's your experience in doing YAG capsulotomy in patients, pediatric patients? And number one. Number two is that how, like you in doing YAG capsulotomy, want to dilate the pupil? That is very important.
Yeah.
You want to fully dilate the pupil, or what is your opinion on that?
So first, like about the pediatric cases you are saying, no, pediatric cases, ideally I try to do a PCC. Because pediatric cases sitting in front of YAG machine is, yeah. And the second question, what you said, like...
Doing the capsulotomy, like what should be the pupil size you like to prefer?
Yeah. So normally, ideally, the pupillary size, like the capsulotomy size, it should be more than the pupillary diameter. The thing is that if your pupillary size diameter and the YAG capsulotomy, that opening, if it is less, there won't be change in the visual acuity. But there are studies which they have shown, like both the photopic and mesopic vision, like especially the contrast sensitivity and the glare, both will get reduced. If your pupillary, if your capsulotomy opening is lesser than your pupillary diameter. So ideally, you should go for a larger
yeah, but one thing is that what I have seen practically is that if you fully dilate, it's very difficult to see the centration of the ear. So if you like mid-dilate it, you can just, we want just a central opening in the capsule. So that practically if you fully dilate is what I have seen for myself, it becomes very difficult to like get that central point of that opening.
Yeah, no, I'm saying the size of the opening, size of the posterior capsulotomy opening, that size should be normal, should be bigger than the normal pupillary diameter, not in the dilated eyes, the normal pupillary size.
Yeah, size is there, but regarding the position which you are talking about, Dr. Nilanjan, I think a semi-dilated pupil definitely gives you a better result, because sometimes you don't know the pupillary position. You do the young opening centrally, and then you see that when the pupil gets constricted, you see that it's not in the central position actually. So both of this regarding the position and regarding the size. Okay.
I think optimum 5 to 6 mm will be enough.
Yeah, because that's that size equilibrates to what she has said. Another point, we know that you have put on a lot of multifocal IOLs. So have you encountered any case where you had to take a decision, a patient comes with this photopsia, and you had to decide whether you have to go for YAG, or because back of the mind you know that that patient might require a lens exchange at a later date.
True.
So has there been, do you have any experience regarding this?
See, that's what
This
I'm saying,
deciding
like,
between
no,
PC,
yeah.
whether to go for YAG or whether to go for
See, anyway,
exchange.
if you do first thing especially in case of premium IOL, like multifocal IOL, first you need to evaluate what is the cause of dysphotopsia. It may be because of the lens itself, maybe because of the foveal fixation difference, and maybe because of the, if you'll do a YAG capsulotomy in the earlier stage, like prior to making a decision, that what happened, the lens exchange becomes difficult. So that is like...
Okay. Thank you so much, Dr.